Good afternoon again, everyone. Thanks for joining us for day 4 of our 5th annual Inclusive Excellence Week here at the VCU School of Dentistry. I am really excited for our speaker that we have this afternoon for you. So a little bit about Dr. Nguyen. She is a public health dentist, wife, mom, maker of things, and an avid systems thinker in all aspects of her life. She is an advocate for person-centered transformative solutions that improve the lives of marginalized people in their communities. And her approach to this work comes from a place of deep personal connection and professional development. She currently serves as Chief Dental Officer at Clinica Family Health, a large federally qualified health center and a nationally recognized leader in health quality and health equity. She was honored by the Colorado Dental Association with the Exceptional Service Award in 2017 and by Oral Health Coalition of Colorado as 2018's Outstanding Dentist of the Year. She's the current president for the National Network for Oral Health Access, serves on the Dental Quality Alliance Executive Committee, holds an appointment as adjunct faculty for the University of Colorado School of Dental Medicine, serves on multiple state and national health and policy-related boards, and is a frequent advisor for dental quality, integration, and chronic disease management initiatives. She was a proud graduate of Rhodes College, the School of Public Health at St. Louis University, the College of Dentistry at the University of Tennessee, and the Healthcare Executive Program at UCLA's Anderson School of Management. So I am so excited for her to be able to join us today. You guys know me. I met her personally in September at an ethics meeting, at a small kind of closed door ethics summit. And in dentistry and dental education, although it's a small world, I meet very few people instantly that I feel like, oh, you're like one of my people. Like we can really talk, we can have some real conversations. And I very much felt that with Dr. Nguyen. So without further ado, I present you to her, and she'll kick off her lecture around making inclusion and exceptional the norm in a professional practice and community health centers. So let's give her a round of applause.
Thank you so much, Carlos, for the invitation to be here with you all today. I will just note that the sound that I hear from you all in the room is a little bit muffled, so I might need you all to speak up if you need to speak up. So, but I'll go ahead and get started. I just want to say thank you first and foremost for the invitation to join you all. I consider it a really special thing to be a part of a week that's dedicated to health equity and exceptional inclusion. So today I want to talk a little bit about, let me see if I can get my slides to advance here. Okay, I want to talk a little bit about the impact of identity and belonging on interprofessional practice and health equity. I'm going to speak to those things through the lens of the community health center movement specifically. So to start, Carlos read my technical professional bio, but I want to share a few things about me, and I'm going to go pretty vulnerable and pretty personal right off the bat. I am a refugee. In her 3rd trimester of pregnancy, my mom and dad escaped Vietnam on a boat, much like the one you see on the left side of the screen here. And they were taken and found, found and taken to a refugee camp in Hong Kong, where I was born. I am also a Southerner. We were sponsored from that refugee camp to Little Rock, Arkansas, which became my childhood home. On the right side of this screen is a picture of me in front of my high school alma mater, Little Rock Central High, which was the site of a major school desegregation event in the civil rights movement. It is in Arkansas where Chelsea Clinton, a former US president's daughter, was my classmate in the public school system, but it's also where I learned English as a second language and received charity care from a privately practicing dentist growing up. I am also a third culture kid, and by this I mean that I have very close ties to my parent country, yet I also feel very strongly assimilated into my new homeland. So I actually get to identify as something culturally unique to both, And it's through this third culture lens that I consider myself very privileged to see the world around me. So just like the places where I started life are not really very typical, my professional path has also been a bit different. I discovered an affinity for psychology as a pre-dental student. So I became a public health professional first, receiving a master's in public health with a focus in behavioral science before I pursued dentistry. And my professional lens, I often describes, follows the order of my training. I am a relationship-focused public health advocate first and a dentist second. I am, like Carla said, I am now the Chief Dental Officer at Clinica Family Health and Wellness. I live and work outside of Denver, Colorado. And Clinica is one of our nation's really special community health centers. Outside of my day job, I also have the privilege of serving as the president of the National Network for Oral Health Access, which Carlos also mentioned. And I'm going to speak a little bit more about this organization later. For me specifically, I navigate in the margins of many of the places where I live and work as a public health professional in a healthcare world, as a dentist in a medically dominant system, and as a woman in male dominated environments, and as an Asian American in white dominant spaces. And just for fun to throw in a couple of more universal examples, I also get to operate as an introvert in an extroverted world, and a lefty literally operating in righty spaces. So I actually come here to this conversation with you all from the intersection of a lot of different experiences. And nearly all of these require me to operate in spaces where I don't know that I'm really included, but to which I know I want to belong. So because of this, I've had some direct experiences with two concepts that are relevant to the conversation today. And the first is intersectionality. There are aspects of my identity that intertwine to create my experience of some advantages and disadvantages that impart some benefits and frankly pose some harm to me personally. This is in contrast to intersectional identity, or the way in which my personal interpretation of my identity makes me who I am, but in a way that's constantly fluid and shifting over the course of my life. Intersectionality, on the other hand, tends to be slightly more stagnant because the societal norms that create it don't really change that much and don't really change that fast. So in general terms, I really want to underscore that both of these concepts are important, but for the sake of starting today's conversation, I'm going to be largely focused on intersectional identity, partly because it's a more universal concept, and more importantly, because I believe that finding connection to equity work is driven by an appreciation of individual identity. Recently, there's been a lot of discourse happening about these two terms, especially. And I want to invite you all into some of my own processing of them, of these two terms, and how I've operationalized them in my own life to date, how I've operationalized them to date, because I reserve the right to change my mind. But the reason why I want to invite you into this space is because there's going to be some terminology that I'm going to use that's going to be relevant to later parts of our discussion. Before I move into the next slide, I do want to disclaim that in sharing what I'm about to share, I'm only going to speak for myself. And I'm going to speak from a deep place of privilege as someone who has roots in marginalized spaces, but who now has the privilege as someone that gets to operate in places of influence. For me, this feels really important to share in order to not normalize experiences like mine, because I kind of think that that's what celebrating inclusive excellence is all about. So when we talk about intersectionality, we oftentimes use terms like the ones listed on the left side of the screen. So we talk about discrimination, microaggression, cultural appropriation, code switching, and gaslighting. These are really problem-focused concepts, and they're really useful to identifying root causes of inequities. They're particularly useful to me as a public health professional to understand where to allocate resources and set policy. However, as a behavioral scientist and someone who has personally experienced the kind of oppression associated with the things on the left side, I find that focusing on intersectionality alone tends to discount my autonomy, my self-efficacy, and my own self-agency. They tend to characterize me as a victim when I know I am so much more than that. So, on the other side of this continuum is my own experience of identity, where I can see deeply the strength in being who I am, having had the experience I've had. It's because of these experiences that I'm able to hold that unique third culture perspective. And I get to operate within a space of something new and frankly, I consider better. In biology, we call this concept hybrid vigor, or something that's stronger because it's intermixed. And I just believe we need to sprinkle more hybrid vigor around. When we operate from an appreciation, or when I operate from an appreciation and acceptance for who I am, I can show up exercising the all teach, all learn philosophy that I think is really critical to inclusive work. I'm better able to appreciate that there are others like me, there are others out there who were literally willing to sponsor me into spaces where otherwise I might not have been. And I can own that I am culturally multilinguistic, which means I possess a level of situational awareness that gives me the superpower to build bridges and make connections. And in the end, I'm better able to offer and receive grace, which allows me to stay engaged in calling others into the work of creating inclusion and fostering equity. Ultimately, for me, the things on the right side of the slide represent how I am an active participant in creating belonging, which enables me to be an agent of breaking free from marginalization and oppression. This concept of belonging is deeply rooted in behavioral and social science, and I think we all know that Dr. Brene Brown is the guru of this work. And she says that true belonging is not passive. It's not the belonging that comes with just joining a group. It's not fitting in or pretending or selling out because it's safer. It's a practice that requires us to be vulnerable, get uncomfortable, and learn how to be present with people without sacrificing who we are. So yes, I have had and will always have experiences that make me uncomfortable, but I do have choice and agency in what I do about it. I have the choice to invest in understanding who I am and to be a vulnerable and active participant in creating belonging for myself and others through it. So this concept of belonging is core to any spaces we choose to enter, be it in our personal lives or our professional work. So understanding my own evolving identity, and including the ways in which I've been marginalized or have experienced privilege because of it, has really been core to making equity central to my work. It has driven me to seek out and find the kind of belonging to have easily spent the last 17 years of my professional life in an equity-focused system, and that is the system of community health centers. So I'm going to turn now to sharing a little bit about this wonderful part of the healthcare world. So in the height of the civil rights movement and the war on poverty in 1965, there were two very different underserved communities that started community medical clinics designed to improve the health of their residents. One was an urban housing project in Boston. The second was a rural, impoverished community in the Mississippi Delta. This context sparked really the first ever national conversation on health equity. And it's also the time frame in which one of the most well-known MLK quotes came. All of this is from which the health center movement was born. So today, the system that's called health centers serves 1 in 10 Americans, or almost 33 million of the most underserved people in our country, through 1,400 entities that are spread across our country. So the key elements to know about health centers are highlighted in the red box here. Community health centers are nonprofit, patient-governed organizations that provide high-quality, comprehensive primary health care. And by that, I mean we provide medical, dental, behavioral health, and pharmacy services. And we provide those services to America's underserved communities, and we serve all patients regardless of income or insurance status. So I want to take a slightly closer look at what all of this means. So the health center program is mandated by federal law, and we're funded by the US government. So I think it's really important to know that health centers are beholden to significant compliance standards. So only once a health center complies with all of the stuff that's on the left side of the screen, and these things are verified with regular on-site audits. So once a health center complies with those things, it then gets access to the things on the right side of the screen, which includes things like a different payment system for Medicaid, discounted drug pricing for patients, eligibility for loan repayment, and then malpractice coverage that it's supplied by the federal government. I would say that I believe that the things on the left side, so that level of compliance, feels really justifiable to support transparency, particularly in the use of taxpayer funds. But I don't want anybody to walk away from this conversation feeling like compliance with the things on the left side in order to unlock the benefits on the right side is easy at all. It's a very complicated process. So I encourage you all to think about this with a level of appreciation for what your community health centers are doing every day and how they're clear on why they do it. Health centers we're not free clinics. So less than 25% of health center revenues comes from public or private grant sources. The vast majority of health center budgets are dependent on patient service revenue, just like most traditional healthcare practices in our country. As nonprofit entities, every dollar that a health center earns covers the cost of the model or is reinvested into more services for the community. So I mentioned before that health centers offer comprehensive health care, including dental services. And there's several aspects of how we deliver care at health center dental programs that's unique. The first is that we're only required to provide preventative services like screenings, cleaning, and fluoride. And we have to apply for a change of scope to do additional dental services like full scope general dentistry. So really what this means is our communities have to say they need the service, and we have to demonstrate the need for it before we actually can provide the care. The second thing is we have mechanisms that are in place to demonstrate that our care is culturally responsive, which means that there are specific investments in tools and staff that we tend to make to show compliance and to enhance the patient experience. Our systems are also professionally integrated. So it's one of the few places in the American healthcare system that dentists work beside physicians, mental health professionals, pharmacists, and other professionals to care for the same patient. And I'm going to spend a bit more time on this aspect of the care here in a minute. And then finally, we have to show that our care is evidence-based and quality-focused. And there are really, truly very few segments of dentistry that can demonstrate this in the way that health centers do. And I'd say that our patients really need us to ensure that our care is top-notch, because our patients, and frankly, the taxpayers, can't afford for us to do anything twice. So in 2023, health centers represented less than 3% of the dental workforce and accounted for only 2% of the US total spend for dental care, yet we cared for 4% of all Americans who access the dental delivery system. These numbers are small overall, but to me, they demonstrate that this is a system that provides exceptional value to all of America because we do it by reaching the hardest to reach. Not only do we care for a more diverse population of patients, but we also do it by delivering measurably higher quality than conventional models of dental care. So in this way, health center dental programs at their core are fundamentally and radically agents of health equity. Yet, less than 5% of dentists work in public health, less than 3% of dentists and 1% of hygienists work in community health. And because of this, I'd frankly say that we can often feel on the margins of our own professions, and this can confer a whole host of oppressive experiences. But as I shared before, I believe we have agency to seek and create belonging and to use our privileges to drive equity. A group of Belgian social science researchers described, I think, this phenomenon really well. Being committed to occupational or organizational groups is beneficial as it is an essential human desire to expand the self-concept, to include connections with others, and to feel a sense of belonging that makes members more willing to contribute to group efforts. So, said differently, active belonging of individuals to groups is critical to the group effort of making something like equity a reality. So for me, I found that belonging through the National Network for Oral Health Access, which is an organization whose founding is a story that's deeply rooted in advocacy. So in the late 1980s, the health center dental programs were closing at a really disturbing pace. We had dwindled down to only 200 programs nationally. There were a group of community health center dentists who galvanized together to protect this critical oral health access for the underserved. And they did it rooted in the belief that the path to health equity in this country is through a strong dental safety net. They recognized that the fact that there was the specific needs of our professional and patient communities were actually not being met, and that they were being marginalized, including by other equity-focused groups and dental professional organizations. And because of all of that, they created NOAA in 1991, which has since created a space of belonging for so many. So today, 1,100 of the country's 1,400 dental health centers have dental programs, and NOAA's membership now includes nearly 6,000 dental professionals and advocates who cared for 6.4 million people in 2023. I was actually asked recently why I work in a health center, what has kept me there for almost 2 decades. And I found that my answer to this question was really simple. I found belonging. I found that I belonged to a profession of people. I found that I belonged with the communities that I have the privilege to serve. And honestly, that belonging has given me power and longevity. Of all the tools that NOAA offers to our members, one of the most important is our annual conference. It's one of the few professional places where I think many of us feel like we get to be amongst our people. And the image that I included here on the right is a spread from this year's post-conference newsletter. And to me, it offers one of the most definitive examples of what professional belonging can look like. I mean, when you look at this, if you see the hugs, the smiles, the high fives, that's a group of really happy people who feel like they're connected to something. So in my mind, health centers are really unique agents of belonging and equity, especially for dental professionals and our patient communities alike. And I want to turn now to a very specific feature within health center dental programs where this concept of belonging also becomes critically important. And that's within interprofessional practice itself. So at present, there are very few dental practice models that incorporate interprofessional practice at really any level. And health centers are the largest by significant margins. So if you look at dental practice models, it's a field that's packed with private practices, corporations, and dental service organizations. And health centers are in the minority based on size. Yet when you look at the numbers, we represent the majority of all integrated interprofessional practices in dentistry. When Health and Human Services was authorized to create the health center movement with interprofessional practice at its core, I think it did so with the vision and focus on improving patient outcomes, improving patient experience, improving provider experience, lowering the cost of care, and fundamentally driving health equity. So effectively speaking, the interprofessional model that's inside health centers is designed to achieve the quintuple aim. And there's been a louder call over the past several decades to make interprofessional practice more universal. This call resulted in the development of the interprofessional practice core competencies. And the most recent revision is in 2023, which is what I've got shared here on the screen. These competencies have now been built into the Council on Dental Accreditation Standards. So dental schools and health professional schools all over the country are teaching these things. And the essential elements of these competencies include definitions for values and ethics, roles and responsibilities, communication, teams, and teamwork. So these are elements that are embedded in the way health centers practice and drive many of the innovations involving oral health that I'm showing here on the slide. And I'm going to note that I'm using the quotes around innovations here really intentionally, because these things are really only innovative because they seek to rejoin aspects of health that really, frankly, should have never been separated to begin with. Anyway, that said, health centers are still amongst the most innovative part of the healthcare system. And a major facilitator of that is structural. So our delivery model makes different healthcare services available to our patients. And this design allows for us to more naturally see the patient at the center of our care. So to paint a picture of what this looks like, let's look at an example here from my own health center. And it's an example of integrated well child care. So around 2010, we were amongst one of the first dental programs in the country to design and implement a medical dental integration program, where we embedded hygienists into medical settings to support upstream dental prevention and care coordination. So in the photo here, you can see that this is a visit that happens within the medical exam room, and the oral health aspects of the visit are considered an essential part of the medical care. And this is a program that we call Hygienist on the Pod, or HOP. So you'll hear me refer to that. So back before we began our HOP program, if you were to have asked our parents why they maybe perhaps were not seeking dental care for their kids, even when we had the dental capacity to see them, you'd oftentimes hear the reply, well, they're just baby teeth. And I think on surface level, it can be really easy to dismiss this as an issue of poor parenting or maybe even apathy. But to do so is actually wrong. Because at Clinica, we had evidence of exactly the opposite from our medical outcomes. Our families were and are actively engaged in taking care of their kids. They seek early prenatal care and vaccinate their children at rates better than the rest of the state. And this is largely because the families were getting in to see their PCPs with whom they had established continuous relationships, but they hadn't yet made that link for dentistry. Frankly, many of our parents and our medical providers alike didn't know that decay in the baby teeth is the #1 risk factor for also having decay in the permanent teeth. And by integrating our hygienists into our medical pods, we dedicated a team member to supporting this link for our families. So this work has enabled us not only to create workflows that, quote, put the mouth back in the body, especially from a care delivery standpoint, but it's also been codified into clinical care protocols in a way that makes it sustainable in the long term as really just a normal way of doing delivering healthcare. So this is demonstrated through how we even communicate to our patients about what to expect in their care. An example of this is how we've embedded evidence-based elements of dental care within the well child guidelines in our practice. So doing care in this way has created a litany of outcomes that support that drive toward the quintuple aim. I'm not going to go into specific details of what's on this slide here, but what all of this demonstrates is that investing in an interprofessional practice, even through this single program, is not only exceptional, but it also creates exceptionally high quality healthcare. So while our HOP program has been largely successful, something like this does not happen without deep intention and work. There are multiple variables to getting this kind of integrated healthcare to happen. And there are barriers that sit at the system, organizational, interpersonal, and individual levels. But the key to developing an effective integrated practice is by intentionally removing barriers, so the stuff on the left side of the screen, and investing in facilitators of interprofessional practice, the stuff on the right side. So for a health center like mine, we oftentimes already have the system and organizational facilitators in place to make this kind of care happen because of our structural design. However, in the experience at my health center, keeping this work going, we found requires the most intentional efforts in the interpersonal and individual realms. So the stuff I've highlighted here in the red boxes. So this means that we have to consistently and actively invest in creating and sustaining effective communication and workflows, team cohesion, shared power, and the belief in the benefits of the work itself. When I step back and take a closer look at the things in the red boxes, I notice something that's really interesting about interprofessional practice, especially given what I shared earlier about the continuum between intersectionality and intersectional identity. Those red boxes make it clear to me that interprofessional practice is a form of belonging. In so many ways, the tenets that drive effective interprofessional practice are the same attributes that I shared earlier as essential in my own ability to find belonging. When we focus on values and ethics, we strive for justice and equity. When we clarify roles and responsibilities, we practice all teach, all learn. And when we center on effective communication, we support inclusion and situational awareness. And when we invest in teams and teamwork, we elevate dentistry, diversity and adaptability. In this way, the skills that drive interprofessional practice and belonging, in my mind, are corresponding competencies that we need to drive health equity. The investments that workplaces and institutions make to support healthcare integration and interprofessional practice cannot work without also investing in belonging. And we have to invest in these things because these investments improve outcomes. So health centers across the country are and have been deeply investing in interprofessional practices and the elements of belonging needed to make them work. And they're seeing outcomes from this. So these are some slides from my own health center that demonstrate that even beyond our HOP program, by seeking a seat at the interprofessional table, we've been able to improve outcomes that matter to us, including things like significant increases in preventative dental care services and dramatic decreases in caries rates in a way that improves health equity. On the flip side of this, a deficiency in interprofessional practice and belonging can perpetuate and exacerbate health disparities and inequities. And we actually have a very telling example of this from the pandemic. During the early days of COVID, notable agencies like the American Dental Association, the Centers for Disease Control and Prevention, and the World Health Organization, they called for closures and restrictions on dental practices, and they did it under the auspices of safety. These actions then actually called into question what we define as essential and what we believe belongs in health and healthcare. In health centers, the impact of those decisions have been very far-reaching, and to me are demonstrative of what happens when we don't support belonging and undervalue interprofessional practice. In health centers, the care disparities have not only widened, but they've persisted even after the end of most pandemic era policies. Before the pandemic, health center patient counts were 25 million for medical and 6.7 million for dental in 2019. Health center medical volumes were completely recovered by 2021, whereas on the dental side, our dental volumes still lag behind pre-pandemic levels even today. Because of the unique populations that health center serves, this disparity in care deeply reflects an exacerbation of inequities for sociodemographically marginalized people in our country. So this graph is a gut punch for me when I think about it in that way. So as a public health professional, I can recognize and perhaps even appreciate some of the very real, very practical decisions that needed to be made during the pandemic. However, I believe we must own that the pandemic era policies, what they did was to marginalize the voices of critically important healthcare team members and diminish the value of the whole health needs of people most disenfranchised by prevailing systems. And as someone who worked in health centers during this time, I can say firsthand that the discussions that we were having about where to allocate resources, like where to send the PPE or the COVID tests, where to allocate space and money, made me feel every bit of the oppressive aspects of intersectionality that I described earlier. Effectively, what I felt was a version of this, that in the wheel of power and privilege, which I've adapted here, where those identities closest to the center sit closest to power and privilege, dental care and dental professionals sit on the outer edge. In the healthcare service space, we tend to sit in a bit of a place of marginalization. So to add some color to this concept, I will never forget one of the most interesting comments I heard from one of our hygienists when we were first rolling out our HOP program. And she said, when I work on the medical pod, I feel like I get to hang out with the cool kids. When I first heard this, I thought of it as just kind of this endearing and kind of vulnerable thing to say. But when I listen to it through the lens of interprofessional practice and look at it through the image on this slide, her statement tends to say a lot more about power, privilege, and especially the desire to belong. There are so many parallels between the sociodemographic divisions that oppress certain groups over others and the healthcare silos that perpetuate inequities. It is my belief that equity-focused work is the work of a collective. And I've spent a lot of time thinking and reading about why anyone would ever join some sort of collective action. And I'm starting to find some answers in understanding things like, why would a person support a foundation for rare cancers, or why someone would choose to start a nonprofit to support special needs kids, or why a provider might choose to work in a health center that cares for new Americans, or really why anyone would ever take a risk at doing something that few others are doing. And I think what I'm starting to learn is that the answer usually lies in their personal connection to the work, that they really feel belonging in the work. For these people, they're able to leverage their intersectional identity to be a part of righting something that feels wrong and of breaking free of intersectional oppression. In healthcare, I think that finding and creating belonging has the potential to mediate a lot of the pressing issues that are before us right now. Things like attracting and retaining a diverse workforce, managing issues of mental wellness and well-being, and I think most importantly, closing chronic persistent health disparities. From the health center standpoint, I know that supporting others to find themselves in our health equity focused missions is an absolute key to growing and sustaining our innovative and exceptional movement of care. So I really think that when we normalize belonging as a critical element of our societal and professional work, we get to create a new third culture. And that culture is exceptional and delivers exceptionally high quality care. For me, I would say I think it's super fun over here, and I hope some of you will choose to join me in it if you're not already here. So as I close today, I'm going to take you back to my beginning. The little girl in this photo is me, right about the time I started to learn English. I will say that my family was poor, but I don't think you'd ever know it by how much care and attention my mom took to curl my hair and make the outfit that I'm wearing by hand. I mean, seriously, she put ruffles and trim and puff sleeves on this dress. But when I see this picture is I see it connected to our work. What each of us gets to do requires the same kind of care and an intention, and it really translates into belonging, opportunity, and hope for people who look a lot like me. So I want to thank you for your interest in this work, for showing up today, and for all the ways you're going to dedicate that care and attention to your professional lives. Thank you, everyone.
So thank you so much. Any questions, either you can put them in the chat if you're online, or any questions in the room at all? Yes. Okay. For someone interested in working in community health centers, how would you recommend getting involved as a new grad?
Yeah. First off, I have to make a plug for NOAA. So if you go to nnoha.org and become a member, that's your first step. For anyone who is still a student, the membership is deeply affordable because it's free. So join and become a member today. And what you'll get connected to is a list serve, and you'll get connected to a job bank. But you also have my email on the screen, so reach out to me and I'm happy to talk to you about it or get you connected to things that you might be interested in.
Any other questions in the room? Yeah.
A loan forgiveness program.
Could you speak to the options around loan forgiveness that you're familiar with in terms of doing this work?
Yeah, so to be eligible for loan repayment, you have to work in a health professional shortage area. And because all of the health centers have to demonstrate need in their service areas, virtually every health center qualifies for loan repayment. Now, there are multiple forms of loan repayment programs. The federal loan repayment programs, they're kind of two tracks. There's the scholar program that you can become eligible for while you're a student, which then pays for your education while you're in school in exchange for a commitment to work in a health professional shortage area. Or there's the Health Service Corps, which you can apply for after you graduate. Then you would then get commitment into, you have to pick a place to work that would qualify for the HPSA, and then they will pay back your loans based on your amount of service.
Any other questions in the room at all? So two things I want to just mention. At the Ethics Summit where I met Dr. and you, tell me how you pronounce your name.
I pronounce it Nguyen, no N.
Okay, you pronounce it Nguyen, no M. So
Yeah.
like, I don't know if anyone's Vietnamese that's in the room right now, but it's like certainly like the most common Vietnamese last name, right?
It's exactly right. Yeah.
Yeah. And so like it's a tonal language, so like people anglicize it a lot of different ways.
But you're right.
Yeah. So I wasn't sure exactly how you say it. Anyway, so I met Dr. Nguyen, and one of the things that I think was really curious about interprofessionalism and even co-location of services. Kaiser Permanente gave an example, like for those of you who've even either had babies or you've been pregnant yourself or walked through a pregnancy with a loved one, there's a glucose test that happens where you have to drink this like horrible concoction where they then, do your blood sugar. And Kaiser Permanente was talking about how in their clinics where they're co-located, you have to wait like an hour after you drink this syrupy stuff, right? So they have the patient drink that, and then they actually have a hygiene appointment set up for them during that hour. So it's not like they're just sitting there twiddling their thumbs, waiting to be evaluated. So it's just an interesting approach that some of our larger systems or some of the community health centers are able to make happen that I think is really interesting. So I thought that was neat. And I'd confirm to you just anecdotally when you were talking about how we're on the margins sometimes of even of the profession, and that COVID laid that out. The students that are in this room weren't here when this happened, but I can, and maybe some of the faculty or staff might remember, when our health system was setting up tiers for who would be eligible for the vaccine. When the vaccine first came out, they were actually on the lowest tier as a part of the health system, where the people who work in valet, like parking cars, were able to get the vaccine, but we in the dental school were not. Like, we were not eligible yet. Like, we were on an even lower tier than that. So I thought about that when you showed the schematic and talked about the way that COVID really showed the lack of belonging even across interprofessional teams. So I just thought that was interesting. Yeah, for sure. But thank you so much. We greatly appreciate your time. Let's give her one more round of applause there.
Thank you all so very much. I appreciate you for being here today.
So we have one more day left tomorrow. The focus will be on advancing health equity through geriatric dentistry. So hopefully join us in room 3105 if you're in person tomorrow, or online tomorrow via Zoom. So thanks so much. Have a great day, everybody.